So good evening, ladies and gentlemen. Welcome to the 13th episode of KSOS Online Journal Club, and happy Vishu to all of you. I'm Dr. Smita Narayanan, editor of the Kerala Journal of Ophthalmology, and I'm a professor at the Regional Institute of Ophthalmology, Trivandrum. With me today are Dr. Najla, fellow at the Contrast Eye Hospital, Kozhikode, Dr. Anju Chandran, consultant oculoplastic surgeon at the Contrast Eye Hospital, Kozhikode, Dr. Ani Sridhar, senior consultant and HOD of oculoplasty and neuroophthalmology at the Little Flower Hospital and Research Institute, Angamali, and Dr. Marian Polly, senior consultant and head, oculoplasty, orbit, ocular oncology and ocular prosthetics at the Girdhar Eye Institute, Kochi. Today, we look into a cross-sectional study from the Aravind Eye Care Systems. This study would be definitely of interest to all the intraocular surgeons. The study is about regurgitation and pressure irrigation, that is syringing, in determining lacrimal obstruction prior to intraocular surgeries. To syringe or not to syringe prior to intraocular surgery, that is the question. Many of us were comfortable after the survey results of the practice patterns of ISAPL in 2017, and we were doing only Rho plus. Now we are not very sure. So today we have Dr. Anju Chandran with us to expertly extract all the relevant information from our panelists and help us to decide how much we should lean towards statistical application of sensitivity, specificity, or positive predictive values, and balance it with the information obtained from relevant studies about postoperative endophthalmitis. So before that, let us first listen to the summary of the study by Dr. Najla. Dr. Najla, please.
Okay, madam. I will share the screen.
Yes.
Good evening, everyone. First of all, let me thank Dr. Smita Madam and KSOS for giving me this opportunity. Today's journal for discussion is regurgitation on pressure over lacrimal sac versus lacrimal irrigation in determining lacrimal obstruction prior to intraocular surgeries. And this study was done by Usha Kim et al. In 2017 and was published in Indian Journal of Ophthalmology in October 25, 2022. Coming to the background, nasolacrimal duct obstruction is a risk factor for post-operative endophthalmitis following cataract surgery. And it causes persistent tearing and discomfort in patients and conjunctival colonization by pathological bacteria, and also cause increase in number of conjunctival commensals. So it is important to check for nasolacrimal duct obstruction prior to cataract surgery. Test used for occlusion of the lacrimal passage. The simplest technique is manual regurgitation on pressure over lacrimal sac, that is Rho plus. And other tests include lacrimal irrigation with saline, Jones 1 and 2 test, and fluorescent dye disappearance test, micro-reflex test, nasal endoscopy, and also imaging such as contrast dacrocystography, dacroscintigraphy, and radiological studies using CT and MRI. In India, the patency of the lacrimal passage is usually evaluated by Rho plus or lacrimal irrigation. Rho plus versus lacrimal irrigation. Rho plus is a non-invasive test and produces minimal patient discomfort and easy to perform in outpatient setting. But it is usually positive only in infected nasolacrimal duct obstruction with mucopurulent material in the lacrimal sac. In the case of lacrimal irrigation, it is invasive test associated with greater patient discomfort and give information of the site of obstruction and in the nasolacrimal drainage system, which may result in definitive diagnosis, and improved treatment planning. And it is also an important tool in diagnosing atonic sac. Coming to the Roplast testing, by tracing the inferior orbital margin medially and superiorly, anterior lacrimal crest is identified. An index finger is then directed behind the crest and apply pressure on the sac area in upward and medial direction, and any reflex of fluid, clear, mucoid or purulent material from the puncta is noted. Those with any regurgitation from either one or both the puncta, Roplast is considered as positive. A similar test called microreflex test was described in the article. Few words on how to perform microreflex test. First, instill 0.25% sodium fluorescein dye in the inferior cul-de-sac and then counterclockwise massage to empty the inferior canaliculus. If the NLD obstruction is present, can observe reflex of fluorescent stained tears from the inferior punctum. Coming to the lacrimal irrigation, topical anesthetic is instilled and lower punctum is dilated with a punctum dilator. And lacrimal irrigation is done using 27 gauge bent cannula. At the time of lacrimal irrigation, those who reported fluid into the nasopharynx are considered to have patent NLD, and those with any regurgitation of fluid, including clear, mucoid, or purulent regurgitation, any fluid passage into the nasopharynx are considered as NLD obstruction. And those who develop a sac swelling post-lacrimal irrigation and fluid went into the nasopharynx after compression of swelling are considered as atonic sac. And those with regurgitation through same punctum from either of the puncta are considered to have canalicular obstruction. Then coming to the article per se, aim of the study was to determine the diagnostic accuracy of manual regurgitation on pressure or lacrimal sac versus lacrimal irrigation for screening nasolacrimal duct obstruction in adults prior to intraocular surgeries. Inclusion criteria include the consecutive patient presenting to the outpatient clinic, diagnosed to have cataract and willing to undergo cataract surgery. And exclusion criteria include active infections like acute conjunctivitis, acute uveitis, acute and 16 years of age, and patient with history of suggestive of nasolacrimal duct trauma. The prospective data collection occurred in 8,323 eyes of the patients who underwent cataract surgery, and all the patients underwent Roplast testing by an ophthalmologist, followed by lacrimal irrigation by trained ophthalmic assistants who were masked to the Roplast status, and this was rechecked or confirmed in equivocal cases by ophthalmologists. These cases then compared for their findings of Roplast and lacrimal irrigation. Those with positive Roplast and NLD obstruction on lacrimal irrigation and negative Roplast and NLD obstruction and atonic sacs were taken up for dacryocysterinostomy with deferral of the cataract surgery. And all those with negative Roplast with canalicular obstruction and patent NLD on lacrimal irrigation underwent cataract surgery with preoperative antibiotic regimen. The results of the study: 8,323 eyes were studied, and mean age of the patients were 62 plus or minus 9.2 years, and 23% were men, and the prevalence of the chronic dacryocystitis in this study was 1.35%. Comparison of the Roplast and lacrimal syringe. 61 cases were Roplast positive with regurgitation through opposite punctum on lacrimal syringe, and 51 cases were Roplast negative with regurgitation through opposite punctum. And in 20 cases, negative Roplast and sac swelling post-lacrimal irrigation suggestive of atonic sac. All this 132 patients, cataract surgery was deferred and DCR was carried out. And all other patients underwent cataract surgery. and there was 0 false positive. Then coming to the diagnosis and management of the patients according to the ROPLAS and lacrimal irrigation status was explained and put as table. And in the cases where ROPLAS positive and regurgitation of the clear fluid, mucus or pus through opposite punctum are taken for the definitive surgery, dacrocystorhinostomy, and those with ROPLAS of clear fluid, mucus, or of the sac swelling are also taken for dacrocystorhinostomy. And those cases with ROPLAS negative and lacrimal irrigation showing patent or regurgitation of clear fluid through same punctum or punctum not seen were taken for cataract extraction. Then coming to statistical analysis in brief, which will be discussed in detail by Dr. Anju Madam. And the ROPLAS testing, the sensitivity which refers to the proportion of the true positive cases that are correctly identified by the test. In this case, the sensitivity was 54.5% with 95% confidence interval of 44.8 to 63.9, and specificity refers to the proportion of the true negative cases that are correctly identified by the test. And in this case, the specificity was 100.0 and positive predictive value was 75.3 with 95% confidence interval of 65.6 to 83.0. And the negative predictive value was 99.4% with 95% confidence interval of 99.2 to 99.5. Moving to the discussion. According to the study, ROPLAS tests have low sensitivity and high specificity for detecting nasolacrimal duct obstruction. Lacrimal irrigation will give information of the site of obstruction of the nasolacrimal drainage system. And it is also a better tool in diagnosing atonic sac also. And the treatment for nasolacrimal duct irrigation and ROPLAS, and none of the study participants developed acute postoperative endophthalmitis. In this study, the sensitivity of the ROPLAS was less, that is 54.5%. And highest possible sensitivity being only 63.9% in 95% cases. And a diagnosis test with a low sensitivity will have a high level of false negative rate, meaning that when the ROPLAS was negative, the patient may be misclassified as not having nasolacrimal duct obstruction in 45.5% of the patients that have nasolacrimal duct obstruction. And the specificity was high, which is 100%, and high specificity of a screening test indicates that if the ROPLAS is positive, the chronic dacryocystitis is almost definitely present. Very limited literature exploring this important question of whether ROPLAS alone can be used to assess the nasolacrimal duct patency prior to cataract surgery. Coming to similar studies, Thomas R. et al. In 1997 studied 621 eyes in which aim was to determine the sensitivity and specificity of the ROPLAS as a screening test for dacryocystitis and compared it to the syringe. Results was moderate sensitivity of ROPLAS, that is 85.7%, and specificity of ROPLAS was 99.0% and negative predictive value of 99.5%. And the study concluded that when ROPLAS is negative, lacrimal irrigation is perhaps unnecessary unless index of suspicion for chronic dacryocystitis is very high. And Bimshetty et al. In 2014 studied 1,255 eyes in which aim was to compare the ROPLAS versus syringing in diagnosing nasolacrimal duct obstruction prior to cataract surgery. And results were NLD obstruction present in 45 patients in whom ROPLAS was negative. And study concluded ROPLAS may miss the patients with NLD obstruction, and ROPLAS is not safe and effective method as lacrimal irrigation in a community setting. And another study by Alam et al. In 2021 studied 134 eyes, which correlate between patient-reported ROPLAS or self-Roplas with physician's examination in diagnosing nasolacrimal duct obstruction. Results were all the patients with a positive history of self-Roplas as nasolacrimal duct obstruction and self-Roplas in 64 and physician's examination revealed Roplas positive in 92. And the study concluded that self-Roplas is nasolacrimal duct obstruction and Roplas can be negative even in the presence of nasolacrimal duct obstruction. There was a survey conducted by Nair et al. In 2015, included a large number of oculoplastic specialists in India, where majority of the respondents, that 60%, felt that Roplas was sufficient to test for nasolacrimal duct obstruction prior to cataract surgery. Coming to another study by J.J. Camara et al. In 1999, studied 200 eyes. Aim was to determine the reliability of the microreflex test to screen for primary acute nasolacrimal duct obstruction. Results was microreflex test has a sensitivity of 97% and specificity of 95% and negative predictive value of 97%. And study concluded that microreflex test is a reliable screening test for presence of nasolacrimal duct obstruction. Coming to the limitations of the study, both Roplas and lacrimal irrigation were done on the same day, which could potentially influence the outcome. And different people observe the test results may result in bias, and study only included patients for cataract surgery. Strength of the study is large sample size. Coming to the conclusion, Roplas when used alone has got very low sensitivity and low positive predictive value in detecting nasolacrimal duct obstruction prior to cataract surgery, as compared with lacrimal irrigation. So, study recommended performing Roplas and lacrimal irrigation in every patient as a part of routine preoperative workup prior to cataract surgery. Thank you.
Thank you, Dr. Najla. Now, that was a very succinct presentation that was very clearly describing the summary. I appreciate it.
Thank you.
Now I invite Dr. Anju Chandran to give us a critical appraisal of this article and tell us about the pros and cons, the strengths and weaknesses of the study. Dr. Anju.
Yeah. Thank you so much, Madam, for giving me this opportunity today. So you heard Dr. Najla, who is at postgraduate at Comtrust Eye Hospital, give you a brief look into the article per se. The job that has been entrusted to me is to do a critical analysis of this article. I'll share my slides. Are they visible?
Yes.
Yes.
Yeah.
Make it full screen, please.
Yeah.
Perfect.
So when I was first approached to do the critical analysis of this article, one thing I realized was statistics do not speak for themselves. They need interpretation. So this is my humble attempt at interpreting what the authors meant in this article. So the article that we are discussing today, as Najla already spoke to you about, is on regurgitation on pressure over the lacrimal sac versus lacrimal irrigation in determining lacrimal obstruction prior to intraocular surgeries. So this was a study conducted by Dr. Usha Kim et al., which was published in the Indian Journal of Ophthalmology in November 2022, which is a peer-reviewed journal with an impact factor of nearly 1.8. It's an interesting study of diagnostic accuracy, and my analysis is based on the STARD and STROBE checklists, which are for reporting studies of diagnostic accuracy and for studies who follow the cross-section design. Let's look at the title first. The condition of interest, which is the lacrimal obstruction, has been clearly mentioned, along with the variables of interest, which are Roplas and lacrimal syringing. The population of interest has not been mentioned in the title. Similarly, one does not understand the study design mentioned here, done here. Above all, the main issue with the title was according to the title, we are understood that it is done in patients who are going to undergo an intraocular surgery, while the entire study is based on patients, only those patients who have undergone cataract surgeries. The abstract clearly points out the objective of the study with a brief and well-structured outline of the methods, results, and conclusion. Research question does follow the PICO format, which is the population here are patients who are undergoing cataract surgeries. The intervention here is the ROPLAS, and it is being compared with lacrimal syringing, which has been taken as the reference here. And the outcome is, of course, diagnosis of lacrimal obstruction prior to the proposed surgery. Though not clearly put in the study as to what the hypothesis is, one can assume that the hypothesis here is regurgitation on, that is ROPLAS, is a reliable diagnostic tool for nasolacrimal duct obstruction in patients preparing for the surgery. The introduction has been put in a very detailed and thorough manner, where the reader gets an insight into the topic, and also the objective as to why the study was taken up is also clearly mentioned. And according to them, there are no studies that have, there is less literature that have compared the sensitivity and specificity of ROPLAS versus lacrimal irrigation to detect NLD obstruction. So coming to the study design, here it was a cross-sectional prospective design. The source has been clearly mentioned. The setting is in a tertiary eye care center in South Tamil Nadu. The period is from January to December 2017. And the method of selection is basically a detailed ophthalmological evaluation, where first the patient is seen by an ophthalmologist and then later by an ophthalmic assistant. And in case of a doubt, the patient is again referred back to the ophthalmologist. So the participants who were included here were all those who fulfilled the inclusion criteria, which have already been described in detail by Dr. Najla. The diagnostic tests have also been described well, and they were performed with due informed consent from the patient, and they abide the tenets of Declaration of Helsinki. Now, regarding the methods, we understand from the methods described that ROPLAS positive means when there is clear or mucoid or purulent regurgitation. So that is positive ROPLAS, which is clearly put across. Whereas when it comes to lacrimal syringing, we are made to understand that when there is a clear mucoid or purulent regurgitation, there is a nasolacrimal duct obstruction. Also, there is a mention about canalicular obstruction and atonic sac as well. But one thing puzzled me, which was clear regurgitation or clear fluid regurgitation on syringing does not entirely mean a nasolacrimal duct obstruction. It also can mean a common canalicular block, whereby on diagnosing this, the management can vary accordingly. How exactly the sample size was calculated has not been mentioned. All consecutive patients have been taken up for the study. So one should assume that the sample size was not determined through a formal power calculation, or perhaps a power analysis was done, which is not reported in the study methods. So out of this arises a number of biases. We shall look at them one by one. One is that only those patients who have been posted for cataract surgery, this particular tertiary center was studied. Patients who took care elsewhere or who did not have cataract may also have different rates of NLD obstruction. Now, detection bias, there is a mention about the technician being masked to their ROPLAS status, but both the ophthalmologist whereas has not been blinded to the ROPLAS status. So also, when you perform the test, it relies heavily on the subjective assessment of fluid regurgitation. And often when we go ahead and do the test, there is a preconceived notion about the patient's NLD status, leading to an information bias. Multiple technicians must have performed the test. So hence there might be an inter-observer variability between the tests. And confounding factors like age, sex, race, and comorbidities, which could affect NLDO, have also not been considered. Having said that, the authors have taken care to mitigate the amount of bias that could be there by excluding active patients with active infections, by obtaining a prior informed consent for irrigation. So the benefit of this is the patient clearly knows what procedure he's up for and also what to expect. So thereby we can, the authors could reduce the number of partial responses or false responses or variable responses. And also all doubtful or equivocal cases were cross-checked with an ophthalmologist. Coming to the statistical analysis, there is a mention about continuous variables being taken as mean with standard deviation, such as age of the patients, and also categorical variables such as gender, the robust result, and NLD patency on lacrimal irrigation, and the need for DCR surgeries. Those were taken as proportions. We already saw that the descriptive statistics have been put across in a clear and concise manner. There's a large sample size of 8,323 patients. And there is a nice little table. But again, like I mentioned earlier, here, where do we put the common canalicular block patients, or where does their management come according to this table is a question that we have ahead of us. So if I am to describe this table, those patients who have a RO+ positive, that means it's indicating an NLD obstruction, and also with a regurgitation on lacrimal irrigation, they invariably undergo DCR. But there are patients who can have a negative RO+ and have findings which are suggestive of an atonic sac and can have regurgitation on syringing. Those also undergo DCR. The rest of the patients undergo cataract surgery. The primary outcome that we are looking here is determines the accuracy of this diagnostic test, which is RO+ here. And this is being calculated by sensitivity and specificity. There is a 2x2 contingency table where the number of patients who fall under each have been plotted. And we shall have a quick look at this. So patients who have a RO+ positive. Yeah. So patients who have a RO+ positive as well as who have regurgitation on syringing are taken as true positive, which is A as per this table. And patients who have a RO+ positive but no regurgitation or is patent is taken as false positive, which is 0 here. Patients who have a negative RO+ but have regurgitation of fluid on lacrimal syringing are taken as false negative here, which is 51. And patients who have both negative RO+ as well as no regurgitation, or rather a free syringing here, is true, taken as true negative. Now there's an outlier here. Basically, there are 20 patients of atonic sac. This kind of bungles with the statistics calculation. We will look into it in detail as we progress. But here they have mentioned that atonic sac was included in the total number of patients who have had regurgitation of clear fluid. So, and all these 132 patients underwent external DCR. Najla mentioned briefly about what sensitivity is. It is basically the proportion of true positive tests that are clearly identified by the by RO+. So here it was 54.5% of sensitivity, which means a positive RO+ clearly identifies 54.5% of patients with nasolacrimal duct obstruction. And by looking at the next statement, we mean that we are 95% confident that whenever this test is repeated, the true sensitivity or the true values of this test will lie between 44.8% and 63.9%. But wait, if you look at the calculation here, like we mentioned earlier, they said that atonic sac was added to this total number and taken as 132. But this has not been done in the calculation. So sensitivity is basically A by A plus C. Okay. And that should amount to around 46.2, whereas which also includes the atonic sac. So the atonic sac should ideally fall in the false negative group, and the values would be different. But here what has been taken is true positive, that is 61 by 61 plus 51 alone. Next is specificity. It is a proportion of true negative cases that are clearly identified by the test. So here it means that there were no false positive. So if there is a patient who had a Roplas positive, that means there is no chance that it cannot be NLD obstruction. And there is high level of certainty in this result. So probably the low sensitivity that we had in this was due to the presence of fibrous lacrimal sac or an encystic mucocele or prior emptying into examination. And somewhere down in the discussion, there was a mention of prevalence being 1.35%. But how was this prevalence calculated? To my understanding, it has been calculated with the values from within the study, which does not add value to the calculation of our other measures of outcomes such as sensitivity and specificity. Now, coming to the positive predictive value, it is a probability that positive test result currently identifies individuals who have the disease. So once again, let's look at this table. So if we look at this here, positive predictive value means true positive, that is A by A plus B, which is you add both the positives. So ideally we should be getting 100% here, but unfortunately during the calculation, the atonic sacs have been added to the true positive value here, and hence the total value differs from what should have been 100%. Now, coming to the negative predictive value, it gives the probability that a negative test correctly identifies individuals with no disease. That means negative Roplas and patent syringing, the probability of there being no nasolacrimal duct obstruction is 99.4%. So coming to the conclusions, at the beginning, the research hypothesis was that Roplas could be an equally effective tool in diagnosing nasolacrimal duct obstruction prior to cataract surgery. But towards the later half of the discussion, both Roplas and lacrimal irrigation together were suggested as a routine preoperative test. And also the limitations of using Roplas alone as a diagnostic tool were also highlighted. In this particular study, none of the 8,323 patients had any acute post-op endophthalmitis. So if we are to look at the drawbacks of the study, being a cross-sectional study, only a selected population at a time was studied, the biases came into play, and a deeper look into statistics calculation would have given a more reliable outcome, and more attention to prevalence of calculation of prevalence. And our quandary, which we had right at the beginning, there is no gold standard as of now still, or no studies suggesting that yes, lacrimal irrigation is the gold standard of diagnosing an LDR obstruction. The study does not establish the same. With that, I would end my critical analysis.
Yes, thank you, Anju. That was a very, very nice critical analysis. And especially you highlighted that when the atonic sac numbers were considered as outliers, and they put in an error in the calculation of sensitivity. And also in their discussion, they have not highlighted why they have considered adding atonic sac to the positive predictive value, why they considered it in that group. So I don't know whether we can go by the results of this study, but this was interesting. It was very, you have pointed it out very well. And I think the discussion with our panelists would bring out more nuances in the study. So please go ahead with the discussion. Thank you very much.
Yeah, thank you, madam. So, welcome, Dr. Mariam, madam, and Dr. Annie, madam. So, with respect to the study, a study becomes successful when we are able to apply it to our clinical practice. So, how much do you think that we can apply from this, or how much is already being practiced? Is ROPLAS alone being relied upon, or do you do both ROPLAS as well as lacrimal syringing in all patients who undergo cataract surgery?
So what we do in LF Little Flower is the physician tests for ROPLAS.
Okay.
Physician under the slit lamp.
Okay.
And the technician does, if the ROPLAS is positive, then further syringing is not done.
Okay.
We conclude there is no canalicular block and there is pus or there is an LD block, and straight away posted for DCS surgery. If the ROPLAS is negative, then the technician or the junior fellow will do the syringing under the microscope. So whatever little amount of mucus or pus or whatever is seen under the microscope, it is not done routinely. I think in oculoplasty it is done by the fellow, but otherwise in other units it is done by the technician only.
Okay.
But she also does under the microscope, because that, so whatever we have trained her that whatever mucus or pus is seen, you have to report.
Can there be an instance where already another person has examined the patient and you happen to get a negative ROPLAS? In that case, where previously ROPLAS has been detected, but when the physician checks again, it's negative, would you go ahead and do a syringing in that patient?
Yes, when the ROPLAS is negative, we always do a syringing, and then a doctor will repeat it under the microscope. But as they have done in the study, it was done at the same day. So ROPLAS was negative, it has been emptied, and then when you do syringing, I don't know what happens. That was done on the same day in the study, no?
Yes. Madam, would you like to add?
Yeah, it's like here, like what we do is we go by ROPLAS mostly. The operating surgeon will check the ROPLAS on the pre-operative day, when they come for the IOL power calculation primarily. Then if the patient is symptomatic, in the sense patient is having watering or any history of discharge, in that case we'll go for syringing, because sometimes in the small sac, then atrophic sac and all, ROPLAS negative, but there can be NLD if the patient is symptomatic. So that will be detected by syringing. Then any past history of SAC surgeries, like past history of DCT or past history of PCR, will do syringing even if ROPLAS is negative.
Okay.
So these are basically, we go by patient symptoms regarding the decision for syringing.
Previous surgery, you will also do probing to see where there is block, no? Canalicular block. Or...
So they omitted canalicular obstruction.
Yes.
How would the management differ?
Canalicular, common canalicular, or the
Common
same?
canalicular. Common canalicular. For the benefit of the listeners, how would the management differ if it were a common canalicular obstruction? Annie, madam, how would you like?
Common canalicular obstruction, and even if it's common canalicular, means the patient is having watering, ROPLAS is negative, so we should consider common canalicular obstruction. Then we do syringing under the microscope, see if there is any mucus, and do probing also.
Okay.
So that is how we diagnose the common canalicular. Oh my God, my obstruction. Okay.
And just
management part, yeah,
madam.
Me.
Oh.
Common canalicular block with clear fluid regurgitation. I will tell them to proceed with cataract surgery, and if the symptoms are, if the patient is very symptomatic, like watering excessive is there, I will give an injection Botox about 5 units to the palpebral over the lacrimal gland, telling them they may have to be repeated. So what do you do, Marian? Then I do.
Yeah, see, in common canalicular block, anyway, diagnosis is clear because rho plus is negative. Syringing immediate regurgitation with a clear fluid, probing soft stop. So in that case, they can have cataract surgery, but we do conjunctival swab pre-op. Thinking that, patient initially had LLDO or later developed common canalicular block, we don't know. So as one, for the safety of the patient, second, even for the medical legal aspect, if the swab is negative, the patient can have cataract surgery. So suppose if the swab turns positive, that means you have to revise the diagnosis. Again, you have to do the syringing, rho plus, and whether it is a small sac, is it NLDO, we have to really rule out. You have to roll out the NLDO in that case.
Okay, one thing I forgot, we tell them to do under topical antibiotics, both eyes for 1 week before prior, that I forgot, before cataract surgery. We add that also. If there is, even if there is common canalicular block only, we can never be sure.
Okay, if the patient is symptomatic and the patient does not want the injection Botox, are there any other options that we can give to the patient? Earlier, conjunctival dacrocystorhinostomy was being done. So,
you can do DCR with intubation if the canaliculus is patent at least 8 millimeters. No, Marian. But tell them it can become blocked again when you remove the intubation tube.
Okay. What is anything to add, Dr. Maria?
Yeah, actually, see, if there is a common canalicular block, we can attempt trepanation with a 50% success rate. Sometimes it will be successful, and then intubate the patient, then remove the tube after 4 to 6 weeks. And if still that not successful, then we can go for DCR with bicanalicular intubation if the patient is symptomatic.
Okay.
Like they mentioned in their study that atonic sac patients have to undergo DCR. Would you advise DCR to all patients with atonic sac at their first visit, or would you keep them under follow-up for some time and then later plan for a DCR? Annie, madam?
Yeah, what I would never do, if there is a swelling in the area of the lacrimal sac area, I would never do a syringing. I've had a bad experience myself and with my juniors also. The patient had come with acute acrocystitis later. So if there is a swelling in the lacrimal sac area, and if the Roplas is negative, I would take it as an insisted mucocele and proceed with DCR.
Okay.
Insisted, because there is it is blocked at both ends. It's not opening, so you do a DCR. Atonic sac, only if the sac swelling is not there, and when you do syringing there is a swelling of the sac, then you can diagnose an atonic sac. I don't think I have had atonic sac cases that common. 8 cases, 20 cases they have reported in 8,000.
Actually, it's a little common towards not part of.
In
fact, there was a 16-year-old who had an atonic sac.
Okay, maybe I diagnosed it after surgery. Very rarely that too.
Madam, would you like to add
some
management on atonic sacs?
Yeah. Atonic sac, once you diagnose, ideally DCT. Initially used to do DCT for atonic sac, but nowadays DCR with a very small lacrimal sac flap, very small, and make a large ostium so that by the gravity it goes down like that. Very small sac with a large ostium so that through gravity it goes down.
Okay. So say if we have a patient with a hypermature cataract or a total cataract, and the patient has been diagnosed with a bilateral NLD obstruction, and the patient is, say, around 60 years of age, how would you proceed with this? Would you keep the patient for, after how long would you want to suggest cataract surgery for the patient?
I would do DCR. But you can do a cataract 2 weeks after under cover of topical antibiotics. We usually do a cataract 2 weeks after a DCR. No problem.
Not sooner.
No DCT. No DCT at all is done.
If the case were to be an urgent retinal detachment surgery or a VR
Okay,
surgery,
you want to make it DCT.
and it is a young patient. So, do we have another option that we do DCR for the
Punctal
patient?
block, punctal closure. That's not safe, I think. I don't know. Marian, what do you say? Punctal
I will
closure.
not, I mean, I will not do punctal portrait.
Oh, yeah.
Actually, even after 1 week, I think
You can do.
1 week, even after 1 week, with the culture, negative culture, you can have intraocular surgery. That's what we do in pediatric cataract and all sometimes.
So, will the pre-operative management differ for patients who have undergone a lacrimal procedure prior to intraocular surgery in your practice? Would you put them? Would you invariably advise conjunctival swab routinely prior
No,
to
we don't do. I don't do conjunctival swab routinely. We don't do.
following lacrimal
We
surgeries?
don't do. Not following. Even if the patient conjunctiva is quiet, if there is no myomitis and if there is no discharge, anything, we don't do conjunctival swab routinely. We stopped doing because patients were getting infected from the conjunctival swab. Those who had a conjunctival swab were showing signs of conjunctivitis and all that. So we stopped doing that. Only one night patients we do sometimes. Some surgeons do. Not all. When the eye is quiet, I don't do. I do cataract routinely also, so I don't do conjunctival swab.
They mentioned
There may be commensals in the conjunctiva, and once you get this positive, then you're confusing the patient and you're confusing yourself. You're getting afraid to do cataract. So why should you do the conjunctival swab routinely? We don't do.
Okay.
So we stopped.
They mentioned the risk of postoperative endophthalmitis, especially in patients who do not undergo syringing. Have you had any instances like that where syringing had not been done and the patient ended up having an endophthalmitis?
We routinely do. If Roplus is negative, we routinely do syringing. Somebody does, and so we don't.
And another interesting question that I had was, sometimes when we do syringing, we see both it being partially free and partially regurgitating. Would you take that as free, or would we take it as not patent? Or would you want to keep the patient under follow-up for some time before undergoing any surgery?
See, if it is a regurgitation, means what regurgitation? Clear fluid or mucus?
Clear fluid.
Clear fluid. So I'll ask the patient if he wants any intervention now. Is it too much? Are you wiping your eyes too many times, or is it blurring your vision? If the patient wants, we will give injection Botox, or we'll ask the patient. We'll tell you can wait for some more time till it becomes a real block, and then you can do. The patient says, no, I want it now, we'll do it.
Nita madam, is there any question that you'd like to ask?
I would like to. I think Dr. Anish said that when the RO+ is negative, they always do syringing.
No, negative, yeah.
Yeah, when RO+ is negative, you always do syringing. So
always for those patients who are posted for cataract surgery.
Of course, posted for any intraocular surgery, you would do syringing. So when do you do syringing? How many days before surgery?
When the patient comes to the OP, means OP, when the patient is getting a date for the operation. At that same time,
it won't be just the previous day?
No.
Would it be?
No. It's all daycare surgeries now. No,
Hello?
they come on that day. Can you hear me?
Dr. Marian?
Yeah, actually, when the RO+ is negative, we will not do syringing. We will do syringing.
Hello?
Okay. When
And Dr. Marian, when would you be doing it?
Yeah. When RO+ is negative, routinely we will not do syringing. We will do syringing only when the patient is symptomatic. For example, patient is having watering discharge or any past history of lacrimal surgeries, either DCT or DCR. Then only we will do syringing.
So you are different from your protocol is different from what is followed with others. So what about your institution, Dr. Anju?
So there was already a pattern that was set before I joined. So routinely all patients undergo syringing. If it is
Even if
Roplus
Roplus positive, even if
is
Roplus positive.
Roplus positive, then they're invariably referred to me. But
Yeah.
otherwise, all other patients who are posted for cataract surgery, they undergo syringing. And often cases where they had mentioned where the puncta is not seen or where there has been regurgitation, they are referred for a reconfirmation as to whether it is free or not.
You must
So-
have heard of those very large studies done by Dr. Haripriya Arvind, where there were about nearly millions of nearly 2 or 3 million patients who underwent cataract surgery with intracameral moxifloxacin. So the incidence of postoperative endophthalmitis in those patients was very, very low. Something around 0.07 or something very low, 0.03%. It came down with the use of intracameral moxifloxacin. Do all the patients routinely at the Arvind Eye Care Systems undergo this thing, syringing?
We do syringing for all intraocular surgeries, and we give intraocular moxifloxacin also for all intraocular surgeries.
So that would be the safest.
Yeah,
But
we can't. Yeah.
But as Dr. Marian said, they do it only if the patient is symptomatic. But they must be also giving intracameral moxifloxacin, isn't it, Dr. Marian?
That let us
You do not know about that. Okay.
I don't think they are routinely giving intracameral moxifloxacin.
I think
They may be
routinely
giving. They may be giving.
They must be routinely giving.
Yeah, we all
intracameral
started
moxifloxacin.
after one cluster came, I think, no, 5 or 6 years back.
So I think how relevant is now the discussion about nasolacrimal duct obstruction when the incidence of postoperative endophthalmitis is so much reduced with the use of intracameral moxifloxacin? I wanted your views about that. But I think if you were more of cataract surgeons, then the views would have been more significant.
Yes.
So,
no,
how many, has there been any study where neglected NLD obstruction has led to corneal ulcers? We have seen, I think, more cases than endophthalmitis. Corneal ulcers because of undetected NLD block.
Yes, possible, because many corneal ulcers, when they come, when we do a syringing, we know that it is
or
blocked.
there is a plus, maybe positive.
So, but
Maybe it may not lead to an acute immediate post-op end-off, but over a period of time, probably they might develop a purulent discharge, and that can maybe lead to a delayed endophthalmitis. I don't think
By
immediate.
the time the wound would have healed, it will never come.
that is it.
By the time the wound would have healed.
And the
I
purulent
think
discharge
what
will be
I think is most of the cases of endophthalmitis are from substances that we introduce into the eye, especially Visilon and the thick substances. No, this, even if you test them, even if you take a sample, you cannot get it because it's maybe sequestrated in that thick Visilon, the thick gel. So those may be the cases that we get post-op endophthalmitis, not some undetected mucus producing an NLD block. That's what I think. I don't know. Maybe wrong.
So this study is not very conclusive. This study does not provide us enough information to make a conclusion that we should do lacrimal sac syringing for all the patients.
Sure.
What do you think? What is Dr. Marian's take on that?
No, actually, that's what this study is very inconclusive. They just did a cross-sectional study and just made a criteria, but it is not really, I mean, I don't know. I think it is not really very conclusive to get an opinion regarding whether to do syringing or not to do syringing. I personally feel Rho plus is more than enough, and if symptomatic, you can do syringing.
Okay, so each institution follows its own
Its own
protocol, and let us all
protocols.
continue doing what we have been doing for all these times. Yeah.
And
Thank you.
moxifloxacin is saving the day. That's what you say. Okay.
I think so, because that
Yeah,
has
maybe.
reduced, the number of endophthalmitis, post-operative endophthalmitis has been dramatically reduced by intracameral octoglossal. So, any other questions, Dr. Anju?
Yeah, I guess that's it from my side. Anything else?
You did a good job.
Thank you.
Anju, yeah.
It was my maiden attempt at statistic analysis.
Yeah.
Thanks to you.
They'll
Smita,
call you.
for
They'll call you
pushing my-
again. They'll call you again.
And it was interesting to do a study in ophthalmology,
analysis. Yeah.
and that would benefit the other specialties was also very heartening, actually.
But in this article, no, the title says lacrimal obstruction, but everywhere it is NLDO. Yeah. So there's lots of ambiguity in the study, lots and lots of ambiguity.
2022. Okay.
So anyway,
Okay, thank you, Smita.
Yeah. Thank you very much for participating. There were lots of ambiguities, as she said. So maybe next time we will have more studies where you can put your inputs. Thank you very much for
Thank you.
attending. And happy Vishnu to all of you.
Yeah.
Yeah.
Same to you.
All of you.
Thank you.
Thank you.
Thank you so much.